Good afternoon, everyone. I'm Dr. Atul Mishra, and on behalf of Signutra, I welcome all of you in today's International NutriVigilance webinar hosted by Signutra and Signutra Nutrition Institute on the occasion of World Digestive Health Day. Now, today, we are not merely discussing constipation, we are discussing a paradigm shift. For decades, chronic constipation has largely been approached as a disorder of symptoms, infrequent stools, difficult evacuation, altered bowel habits, and consequently, most therapies have focused on mechanical or symptomatic relief. But modern science is asking for a deeper question. What if constipation is not just a motility disorder? What if it is also a microbiota disorder? Now, today we are beginning to understand that the gut microbiota is not just a silent bystander. It may actually be an active therapeutic target influencing gut motility, intestinal function, and overall digestive health. The shift is opening the doors to a completely new era of precision modulation in constipation management. And with that, let us begin this exciting scientific journey of gut microbiota as a therapeutic target in chronic constipation. I welcome all of you once again to this NutriVigilance International webinar. On behalf of Signutra, I'm humbled and honored to welcome our faculties and experts. Please welcome Dr. Anders Henriksen, Application and Technical Support Lead, Asia Pacific, IFF Health Sciences. Dr. Anders, it's a wonderful honor for all of us to have you on this panel. Now, based in Sydney, Australia, Dr. Anders and his team are developing probiotics based dietary supplements, foods, and beverages for the Asia Pacific region. Passionate about microbiology and the gut microbiome's positive impact on human health, Dr. Anders holds a PhD in microbiology from the University of Gothenburg, Sweden, and completed postdoctoral research in gastrointestinal microbiology at the University of New South Wales, Australia. Our second speaker today is Dr. Hardik Parekh. He's a DM gastroenterology. He is also the director and consultant gastroenterologist at Ahmedabad Gastro and Liver Hospital. Welcome, Dr. Hardik. We'll understand from you how challenging constipation is in India and what some of the clinical realities and treatment challenges of constipation are. Our keynote speaker for today, Dr. Suvarna Lakshmi Garapati, she is a PhD in microbiology, senior application scientist, human probiotics at IFF Health Sciences. She has over 13 years of industrial experience in probiotic product development and technology transfer. And she has a deep and sound understanding of behavior of different probiotic cultures, fermentation tools, applications, process improvements, media optimizations, using a lot of statistical approaches and formulation development. Thank you so much, Dr. Sovana, for being a part of this webinar. Now, I'll not waste much time, and I'll ask Dr. Enders to please give us a small talk on the global perspectives of probiotics in modern healthcare, evolving science, and what are some of the future directions. Over to you, Dr. Enders.
So hello everyone, see if I can get this. So can you see my screen, everyone?
We can just see you, not your screen as of now.
Okay.
Yes, yes, yes. Just put the presentation. Perfect, you can go.
Okay. Yeah, so good afternoon, everyone. It's a great pleasure to be here and to get this opportunity today to talk a little bit about probiotics in modern healthcare. So I think you're all very familiar with probiotics, that they are live microorganisms that, when administered in adequate amounts, confer health benefit on the host. And I think what I'd like to emphasize here on this slide is the fact that there are a vast number of strains out there. that are used in different probiotic formulations. And these are all different. So if we look at a species like Lactobacillus acidophilus, for instance, that they many of them they may have very different properties. So if we have one strain of Lactobacillus acidophilus, for instance, that have been used in a clinical trial and delivered some really interesting results in that clinical trial, it doesn't mean that other strains of that species, other Lactobacillus acidophilus, will give the same result. And this because some of these strains from these species can be very different. So it's very important to keep in mind when we are formulating products for specific conditions that we need to use the right type of strain. Now, if you look at clinical studies in which these strains have been used, over the years, you've had a large number of clinical studies conducted demonstrating that different strain may have very different properties. So you have some strains that may be used to reduce things like antibiotic-associated diarrhea. You have strains that have been shown to reduce eczema or prevent development of eczema in young children. You have strains that have been with their clinical studies supporting that certain strains will reduce things like constipation, prevalence and severity of constipation, and other things. So there is a vast number of papers out there to support use of probiotics for a range of health conditions. Now, if we look at claims around probiotics, and if we look at new product launches over the years, and the health benefits that are associated with these products, I think the vast majority of them, if you look at digestive health, 85 to 92% of these products are targeting digestive health. You also have a number of launches that of products that have been targeting immune health related claims. If we look at what's happening in recent years, you see also a strong interest in other type of conditions like the brain and mood through the gut-brain axis, for instance. You have a lot of interest in probiotics, to use probiotics to improve women's health, skin health, weight management, and a number of other things. So if we look at the growth that has happened in these segments, are really quite significant. So if we look at the CAGR, we're looking at a CAGR of 11 to 22%, so quite significant. Now, let me just give you a little bit of background to our probiotic and our probiotic business. Our journey in this area started in the early last century with the Marshall Laboratories in the United States. At this stage, we were mostly working with milk coagulants and strain selection, mostly for the dairy industry. So many of those strains that are being used in dairy fermentation are related to probiotics. So that's how our journey started. And over the years, we have acquired a number of different companies, and their technology has then been incorporated into our current probiotic business. And among these, we have Rhodia, for instance, 1998. We have Danisco, incorporated in 2004, and we have DuPont in 2011. And these businesses have all brought their own expertise related to culture medium fermentation and harvesting, freeze drying technologies. We have a large team working with genetics, classification, and identification of strains, and of course, teams that are working on clinical studies related to our probiotic strains. If we look at our production facilities, our probiotics are mostly produced in the United States. So we have two large sites here. We have one in Madison, and we have another facility in Rochester in the US. We also have some production in Germany, production of probiotics in Germany. And in France, we have mostly production of starter cultures, but also some probiotics. We also have production of finished formats in the United States and in China as well. And of course, we have a significant network of application support as well. And if we just look at the Asia Pacific region, we have a large facility in Shanghai, China. We have a large facility in Sydney, Australia. This is where I'm based. We have application scientists in Singapore, and we have application expertise in India, both in Delhi and in Hyderabad. Now, so manufacturing and good manufacturing of probiotics is really key. And there are a number of steps here that will influence survival and stability of probiotics. And this is really critical in ensuring that we have the right level of probiotics in our finished format, which could be a capsule or a stick. It starts really with strain selection. Screening for the most stable strains and use them as much as possible. But stability is also influenced through the fermentation. So important that our probiotic strains are given the right type of nutrients during the fermentation process to make sure we get the most stable strains. Concentration through centrifugation is key. And also the last few steps of the manufacturing process where we use stabilizers and freeze-dry the cells in order to ensure that we get the right sort of encapsulation activated and help in protection of the probiotics, not only during the freeze-drying but also during the subsequent storage in the finished format, which could be a capsule or a stick. So why is microencapsulation so important for probiotics? Well, probiotics are living microorganisms that can be subjected to many environmental stressors. They only work if they stay alive and reach the gut at sufficient dose. And this is where matrix encapsulation comes in, because this type of encapsulation provides a microscale protective environment. It surrounds the probiotic cell with a protective matrix that helps them stay stable in the bottle or in the stick over the course of shelf life. It helps to protect the cells against the harsh acidic environment in the stomach and help the probiotics to reach the intestines alive, where they can exert their health benefits. And this is a very simplified view of what it looks like. You have the bacteria, the probiotic cells encapsulated in a protective mix. This is how they are freeze-dried. One way by which the microencapsulation works is during the freeze-drying step. So we have the cells that are still hydrated. They are surrounded by more water molecules, and these water molecules helps to stabilize the cell membranes and the cell walls of the probiotics. Now, if we don't stabilize the cell using these microencapsulation, we will destable the membranes, and this is causing damage to the cell membranes and the cell wall of the probiotic culture, and that cause the cells to, in some cases, not to die during the fermentation, during the freeze-drying process, and the subsequent storage in the finished format. So that's why we use these type of stabilizers to stabilize the cell walls and the membranes during the fermentation process, during the freeze-drying process. And this improved cell health makes the cell very resilient then subsequent in the finished format as well. And this is what we can achieve using these type of technologies. So using a conventional technology, we get significantly lower yields of probiotics during the production, during the fermentation, compared to the patented technology that we use to improve the yield. You also see significant improvement in stability, as I mentioned. So if we compare the traditional technology, so this is the purple line in the graph to the right, you see significantly lower survival of probiotic during over course of shelf life. So it's 50 times better stability in this case. So I think you're using these sort of technology, combining that also with adjustments in the fermentation media that we use, or the concentration after the fermentation. We have managed to do some great things with some of our probiotics. For instance, in this case, we are looking at a Lactobacillus paracasei strain that had very interesting strain in a clinical setting, some really interesting properties. The problem many years ago was that these conditions that were used in manufacturing gave a very relatively poor stability. So it's losing a lot of viability. So we changed the manufacturing process, and with those changes, we managed to then achieve significantly higher yield and also 95% better recovery after 24 months storage at room temperature. And as you see, there is no viability loss or notable viability loss of the strain of the over 24 months at 25 degrees Celsius. And this is important because at the end of the day, these strains and what we can see here is a scenario where we have no viability loss or very little viability loss over the course of 24 months at 25 degrees, and even at 30 degrees Celsius, these are stable. So I think, yes, this is just highlight some of the technologies that we are using in order to ensure that the probiotics are as stable as possible and they meet the needs of the finished format and the final product that they are used in. So yeah, that was my introduction.
Well, thank you, Dr. Anders, for you are here representing more than 120 years of what good work IFF has done for probiotics, and you talked about some techniques. So maybe we'll take some questions on some of the techniques at the end, which influence the survival and stability of all these probiotics. But thank you so much for this wonderful perspective as globally what has been being done on the forum of probiotics. Now I'll move to Dr. Hardik. Uh, Dr. Hardik, I would want to understand from you for our audience that how chronic constipation in India is a challenge, and what are some of the clinical realities and treatment associated challenges also.
Yes, these my slides are visible now?
Yeah, perfect.
And I'm audible?
Yes, of course.
So thank you so much, Dr. Atul, for inviting me for the lecture. And today I'm going to brief you about the clinical aspects. What about the chronic constipation in India? And the given topic to me is clinical reality and treatment challenges. So the first thing what I want to tell you about that, if you understand the epidemiology spectrum of the constipation in India, so it is conventionally believed that the vegetarian diet, because we are more in vegetarian side, so vegetarian diet is less associated with the constipation. But if you see a spectrum in India, that the functional constipation, which is the most dominant, about 60 to 70% of the cases, where IBS-C associated constipation is 10 to 20% of the cases, and organic causes secondary 5 to 10% of the cases. Now, constipation is more common in females. This is a spectrum what epidemiology of constipation in India is. So it is more common in females, and if you can see why it is in females, because it is exacerbated by a recurrent hormonal shifts, especially during when they achieve puberty, then they have to go through a pregnancy and then again a menopause. So these hormonal shifts are responsible for more constipation in females. As well as in India, there is widespread social hesitation in reporting. So this leads to underreporting, but overall prevalence are increasing and it is up to 16%. So what are problems related to India particularly? Because the patient's presence late after years of self-medication. Here, the OTC laxatives and herbal remedies are so prevalent that, and it gives a stimulant laxative effect. So yeah, the people used to take it on and off, and they come to a medical personnel only after years of the disease. Especially the anthraquinone-based herbal preparations are widely used in India, and that is responsible for electrolytic disturbances and cathartic colon. And ultimately, sometimes it can mask the colorectal malignancy as well as structural disease of the intestine. There are multiple consultations before the specialist referral and significant overlap of anxiety and psychosocial stressors in this subgroup of patients. Now, I told you already, because it is always believed vegetarian diet are always provides an adequate fiber. So it is, I will consider it is a fiber illusion. So because here we have now, from the westernization of the diet, we are reaching high in refined carbohydrate intake, which is refined flour and maida, and fast food, which replacing the whole grains. Second, cooking and over processing, like deep boiling, frying, peeling, that removes the fibrous content of the vegetables. In along with this, physiological medical condition like a slow gut transit and comorbid things like diabetes and hypothyroid is rampant in India. So along with this and psychological aspects, so whole this will lead to increased incidence of constipation more and more in India as compared to the Western aspects. In addition to this, nowadays there is a culture like a sedentary work culture and prolonged sitting, like suppression of defecatory urge during work hours. I need to go to work at 7 o'clock in the morning. So I wake up at 6:40 and go at 7 o'clock in the morning. So we don't get time to urge to defecate. In addition to this, reduced physical activity, cooking, overprocessing of food, irregular meal timing, and psychological stress. So all are these factors which is responsible for more and more constipation. So how is the Western standards are different from Indian reality? In Western, 3 to 21 range of stools per week is considered to be a normal individual. While as compared in India, everyone should defecate 1 to 2 times stools per day. That is considered to be a normal now. Stool consistency, I'll show you the Bristol stool in the next slide, where it considered to be 1, 2 is harder, but in our normative values are softer, that is Bristol 4 and 5. So Bristol 3 is considered to be hardened for Indian patients. If you see a definition wise, the weight, stool weight wise, that is 100 to 150 grams in Western as compared to 350 grams, that is high fiber. It's mistake, 350 grams in high fiber diet. And if you see a Western standards, it is a frequency centric, passing 3 times a day to 3 times in a day to once in 3 days, considered to be normal for Western standards. As compared to here, the main is consistency about the form centric and perception. So this is just a go through. Means if you are a straining, you have a hard stool, you have a sensation of incomplete evacuation, anorectal bucket. The Rome has given a beautiful classification that is defines the constipation. But this all about I am talking about the functional constipation. So constipation pathophysiology wise divided into three aspects. One is where the transit is normal, it is called as normal transit. Where the transit is slow, that is slow transit. And a part of subset only have the problem in the lower aspect of your rectum and evacuation problem. And that is called as a dyssynergic defecation or dyssynergia. So here I told you about that Bristol stool form score. And you, as you can see, type 1, type 2 is called where the transit is slow, and type 5, type 6 where transit is faster. Same way constipation is less and water content increases, it is more diarrhea. So 1, 2, constipation, 3, 4, 5. No, 3, 4 is normal and 5, 6 is considered to be a diarrheal stool. But India, there is a distinct for type 3. So this is same way how you will differentiate from constipation from an IBS. So patients of IBS will have definitely have a pain. So pain is a surrogate marker to differentiate constipation from IBS. The bloating can be a symptom in both constipation as well in IBS. Distension can be symptom in both bloating, constipation and IBS. But the pain is a classical symptom which differentiates it from the idiopathic constipation and IBS. Here you can see this is a report of India versus US. where the Bristol 3 is very highly reported as constipation in India as compared to the US counterpart. So in our definition in India, it should, according to the literature, it should include Bristol 1, 2, and 3 as a part of the constipation. So you need some change in defining criteria. And the takeaway that sometimes patient's perception, consistency of the stool is normal. Patient, I am not passing the stool, I have incomplete evacuation. So patient perception sensitivity is very high in India as compared to the US. So clinician must evaluate the consistency type 3 and patient perception over the raw numbers. It's not just the numbers. So this is what I would advise those who are clinicians here, that mandatory to do a digital rectal examination in every patient who presents to you with the constipation. Why it is needed? Because it has 82% positive predictive value for detecting the pelvic floor dyssynergia. Because majority of the patients when come to you, they are prescribed laxatives and you miss the dyssynergia, and especially the obstetrical histories where chances of dyssynergia is very high. So you have to look for perianal area for any fissures hemorrhoid, which is related to a part of complication. You have to check the sensory sensation, which is reflected by anocutaneous reflex, resting anal tone, which reflects your internal anal pressure, and squeeze pressures, which reflects your external sphincter. So, and push maneuver, where you can check the puborectalis muscle. By putting a finger, you can know this patient is suffering from dyssynergia or not. So this is mandatory when patient comes to you in OPD practice with history of only constipation. Don't forget the common secondary causes of constipation. You can say here the good list of the causes, but always we know about the red flags in constipation, the age, the bleeding for rectum, iron deficiency anemia, weight loss. These are the symptoms where you should think, not delaying the investigation. And these are all causes where thyroid and diabetes and Parkinson are common causes that you should not mistake as a part of constipation. And don't forget about the medication list. So medications, you see the common medications that is responsible for the constipation, even commonly prescribed calcium, iron, and beta blockers, calcium channel blockers. So these are the drugs which are antidepressants. So these are the drugs which can produce constipation. So you know about the GI motility when you come across the constipation. So it is very difficult to give the idea about in 15 minutes about the treatment of constipation, but basic, all the patient whenever they comes first for consultation, every patient should be taught about the lifestyle modification first. So ample amount of the life spending time to explain about the lifestyle modification, explaining the high amplitude peristaltic contractions occurs in the morning. You have to use that kick, you have to use it with the meals. This is most important. Along with this, you assess the fiber content of their diet. You can ask them to increase the fiber content. You can add on fiber. Then you can go for your emollients or stool softeners. Then comes the osmotic laxatives. Then comes the stimulant. But majority of the time when patient presents to us, they have already taken stimulant laxatives when they present to a tertiary care center. Above which, the newer medicines, there is a now a armamentarium of medicines including alobixibat, prucalopride, placanetide, linaclotide. So there are ample amount of medicines are now available which is responsible for the colonic prokinetics and secretogogues. Along with this, you have to go for the rare in practice, that is sacral nerve stimulation, and very rarely a colectomy. So rather, I would like to classify the understand the pathophysiology in your patients, what causing constipation is. So the first thing, if you think that there is something wrong in your dietary habit of the patients, then changes of lifestyle is the first step. Second, patient presents with primary constipation, you have to use laxatives as well as secretogogues. When you suspect outlet obstruction, dyssynergia, you have done a digital rectal examination, so then you that case you do about biofeedback therapy. And a condition where you suspect a colonic inertia, prokinetics, and colectomy is the only answer, which I have not done much in my clinical practice. But we have to understand the pathophysiology, whether you are dealing with a slow transit constipation or you are dealing with a dyssynergy. So this is just, I want to highlight the drugs which currently we are having in armamentarium of an management of constipation. As you can say, the main role of osmotic laxatives are polyethylene glycol, magnesium, and lactulose to bring the water inside the colon. Here, the stimulant laxatives, you can see they can block the channels and they can stimulate directly to the intrinsic smooth muscles of the colon. That is about senna, which is widely prescribed, picosulfate, and bisacolide. Nowadays, the newer medicines which are available, which is a chloride channel blocker, that is lubiprostone, which can increase the water content of the stool, as well as cyclic guanyl cyclase receptor inhibitors, that are the linaclotide and plaquenilide, which can also increase the water content of the stool. Prucalopride is a colonic stimulant that works at the level of the myenteric plexus and muscular pathway. So these are the just brief about the pharmacological treatments which is available. As we are discussing more about the microbiome, now microbiome has been implicated from long standing in a pathophysiology of constipation. And here you can see the gut microbiome regulates the 5-HT levels through multiple mechanisms which influence the colonic peristalsis and contributing to a constipation. So, and there is a second thing, that is the bile acid metabolism, because activation of the chromaffin cells, FXR and TGRs, that stimulates the release of serotonin and CGRPs, that is initiate the intestinal peristalsis. Short chain fatty acid that is produced by the microbial fermentation, it can promote the colonic peristaltis, and which can stimulate the secretion of gastrointestinal peptide YY, GLPs, and 5-HT synthesis. So the drugs which can work on this SCFA or the probiotics which work on methane production, because methane has been shown that it can reduce the defecatory frequency on an individual. So drug which can work on this subgroup area or the probiotics which working on this subset will work definitely for in patients with constipation. So we can change about the lifestyle. I told you, just dietary re-engineering is much more needed, and you can from polished white rice and refined maida you can shift to a fiber-rich grains like ragi, jowar, and bajra flax seeds, and you should be having a intestinal motility and posture controls. So key takeaways from the practice, that high prevalence in India, chronic constipation is common and it is underreported. Symptom-based diagnosis is more important than only a frequency-based. Digital rectal examination is mandatory for a clinician. Physiology-based studies, though it is limited in India availability to a specialist center only, but refractory patients requires motility testing, and tailored treatments is more important, where you need a colon transit study or MRI difficography. And you can regulate the OTC use as well as early screening and integrated care, as we can improve the clinical strategy for doing this. I think, thank you so much for any questions. I'll help to answer.
Yeah, thank you, Dr. Hardik. I think you gave a brilliant perspective as to what is happening in India in terms of high prevalence and incidence of constipation. What are some of the treatment modalities available in terms of pharmacotherapy, and what clinically should be now adapted and adopted in clinical practice. So you also touched upon briefly about the probiotics. I'll invite here our keynote speaker, Dr. Suvarna, to just pick from where you left and give us a complete holistic overview of gut microbiota as a therapeutic target in chronic constipation. Dr. Suvarna, welcome. Meanwhile, by the time Dr. Suvarna puts her presentation, I'll request all the audiences, they have a text box. They can text in their questions to Dr. Anders or Dr. Hardik Parekh, who is a gastroenterologist, and Dr. Suvarna, who is a probiotic scientist. So they will be waiting for a lot of questions from your side.
Are you able to see my screen?
Yes, just make it full screen, ma'am.
Yeah.
Yes, yes, yes. Please proceed.
Yeah. Good afternoon, everyone. Of course, I'm not able to see everyone, but try to make use of this session as interactive session. And one more request is, I'm under the weather with due to the throat infection. In between, if I sip some water, please allow me. Yeah. Uh, After Hardik introduction to probiotics, role of probiotics in constipation, so I'll take that relay torch to emphasize what is the importance of gut microbiota in chronic constipation, and pathophysiology of constipation. Already he explained. So from pathophysiology to pressure modulation, instead of acting on a symptom based, how do we go with the precision or personalized modulation, that I'm going to talk about. That is the today's topic, and I want to create a impression. So what are the current uh, assumptions on the probiotics, and what is the real picture? At least if some of the impressions, if I give, it would be my pleasure. So moving on to the next slide. So I don't know how, I cannot see my chat box also, I think so. Mm, okay. I think we know gut microbiota. I think it is very prevalent topic, and anybody nowadays they are talking about probiotics. But you know what is the number of gut microbiota in our human body? So it's around 10 power 13 to 10 power 14. That means it's a trillion, 30 to 40 trillion number of probiotics are there in our body. That is, it's almost equal to our human cells. That means we are apart from our organs, we are having one more organ, invisible organ, that is called gut microbiota. Imagine 30 trillion of microbes are there in our body. Still we are depending on the external sources of probiotics. When we grow these probiotics, we can able to achieve only 1 trillion to maximum 2 trillion number. But see here, the number is more than 30 trillion. So that is the mechanism, that's the evaluation how our body composition is made up of, because that is the only channel, gastrointestinal channel, that is the only channel we interact with the external environment. We take lot of food every day, and we consume lot of along with the beneficial bacteria, we consume lot of harmful bacteria, and they should not enter into any our enteric systems to create any septicemia or pathogenesis. So that's why this gut microbiota are continuously they are policing our body, but still we are humiliating them, and always we are getting dysbiosis and getting diseases, even though we have this much of number of microbes are there. So what is exactly made up of this microbiota means? So around in our human bodies, already mentioned, tens of trillions of microbial cells are there in our body. They are belongs to different species. Among them, not only bacteria. In our gut, it contains protozoans, virus, other yeast. Many bacteria are there. But coming to the probiotic, they are good bacteria. They already considered as a grass. That means they have generally regarded as a safe for consumption based on some properties. Like in India, ICMR and WHO, they relate some guidelines. So particular bacteria needs to be considered. What are the guidelines are there to consider it as a probiotic? So among these 1,000 species, lactobacillus and bifidobacteria are major probiotics. Lactobacillus comes under Prevotella, whereas bifidobacteria comes under actinobacteria. Along with bacteroids is one more number. So based on our coming diet and the area where we are living, so these number the gut microbiota diversity will be changed. In some population, Prevotella number will be high. In some population, bacteroids number is high. In some, actinobacteria number is high. Okay, so based on this number nowadays, this microbiome analysis is very prevalent, and people are doing, trying to understand which ratio is better for the human. So among these 1,000 species, and imagine how many 1,000 species are there, and 30 trillion bacteria, how many millions of microbial genes are responsible to create these metabolites? Around 5 lakhs metabolites are produced by this gut microbiota. So among these 5 lakhs, around 5 lakhs of metabolites, around 30% of metabolites which are there in our body is from microbiome. That means how important microbiome, how deeply we need to understand how to take care of these tiny friends in our body. That we need to do that. So from past 15 years, so much of research is going on. It is, microbiotics are not only, even though they are residing in the gastrointestinal tract, They are not only confined with the gastrointestinal, so they have wide variety. They have access to other interaction with other major functions also. In the coming slides, I'll explain how they are related, how they change the scenario of our maintaining balancing of our human health. If you see here, this is our epithelial layer. So whatever I'm seeing, these rods kind of a thing, these are organisms, microorganisms, and the small balls are like toxins. So these, whenever we take any kind of a food or water or any kind of a thing, so they don't allow anything to go into the system, enteric system. Like this is our epithelial barrier. It tightly protected by these microbes. So whenever we have any dysbiosis or any imbalance is there in our microbiota, so these pathogen bacteria will go into this epithelial. That is called leaky gut. Nowadays most of the people, they are facing this issue, leaky gut, and always some disturbance is coming on the back. Can you please mute it? So this is epithelial barrier. So these probiotics, they produce short chain fatty acids and other metabolites, and they pass through this epithelial layer. Only they cannot allow other microbes or even themselves. They cannot enter into the epithelial barrier because the design is like that. Whatever you are seeing, these horizontal bars is called tight junctions. They don't allow any other bacteria or pathogenic bacteria or even probiotic bacteria into our circulation system, enteric nervous system or circulation. Only they can allow only metabolites through the system. So these metabolites can activate this our immune system, enteric nervous system, and they have this connection with our brain. This is called gut brain axis, then followed by circulation, then ultimately it is causing systematic effects and beneficial effects to the major organs. So whenever this system, this dysbiosis happens, that means the whatever number we mentioned earlier, if any balance is out, then these are the complications we face. These are the major diseases. Of course, this is number. So they we can end up with the cardiovascular, obesity, diabetes, as well as inflammatory IBS. Of course, it's a very direct link with the gut-brain axis. Nowadays, scientists are they are trying a lot to understand the interaction between gut to brain axis. Inflammatory bowel disease, it's like a psychological disorder. It's like stress. Whenever we feel stress and anxiety, you want to go with the either constipation or diarrhea. So that is majorly because of the signals. Here I mentioned the nerve plexus, the interaction, how these gut microbiota, the metabolites, how they stimulate the system that impacts, and so many other diseases, hypothyroidism, is because of the dysbiosis. These are all disease are possible. And similar to what Hardik mentioned earlier regarding constipation, how it impacts, the same way here, the gut microbiota, whatever we mentioned earlier, why we need probiotics, why supplements are needed, because of the dysbiosis. We are not able to maintain our gut properly due to these all these factors. The first one is, as he mentioned, it's a diet. Because of the westernization, we are not taking fiber food. We are all depending on the processed food. And fiber we are talking from the past half an hour fiber. So in the coming slide, I'll explain how it is linked with gut microbiota. What is the role of fiber into that? The second one is travel stress. Whenever we go out and always we have this diarrhea kind of a thing, that is because of the stress. And medications also leads to these dysbiosis of this gut. And last one is age. Anyhow, when age progresses, when from the mother the child gets bifidobacteria, eventually when age progresses, this bifidobacteria number will be decreased. But as we know, bifidobacteria are they can able to ferment better, but fiber can be fermented better by bifidobacteria and produce short chain fatty acids in the large intestine. When age progresses, these number will be decreased. Because of all these factors, and of course metabolic diseases also leads to this dysbiosis and hormonal dysregulation also. So GI symptoms among all, now I'm going to talk about constipation. So how it is linked with GI symptoms are linked with dysbiosis, I'll speak. I'm not much spending on this slide. Anyhow, I'm going to pick up constipation from this. So as Hardik mentioned, of course, he gave very detailed explanation. Here, basic is here according to, of course, coming to the disease pathology. I am also like a common man. So what I understood is three bowel movements per week. If it is lesser than three bowel movements, then we can consider it's a constipation. If it is larger, longer condition like at least 3 months, the situation is persistent, then we can consider it's a chronic constipation. The major observations are slow transit, intestinal transit or evacuation, and always we have that stress, psychological stress, because we won't be very comfortable with this condition. These are the symptoms. I'm not going to the deep of these clinical symptoms. Reduced stool frequency and hard and dry lumpy stools, and feeling defecation problem, and feeling incomplete bowel emptying, and abdominal discomfort. So now I want to emphasize what is the role of gut microbiota in constipation now. This one also I'll skip. Only I'll take it up gut microbiota interaction, because already these three covered by Hardik earlier. So now I'm going to talk about gut microbiota interaction with constipation, how they linked with constipation, what is their role, how important they are. As I mentioned earlier, what is dysbiosis? When the beneficial bacteria like lactobacillus or bifidobacteria number is decreased, then it is called dysbiosis. So what is happening when the number is decreased? Whatever food, whatever fermentation they need to do, they convert into whatever food we are giving, they convert into short chain fatty acids. When the number is decreased, obviously the fermentation capacity will be reduced and leads to lower short chain fatty acid production, which leads to improve gut motility will be decreased because of the lower short chain fatty acid production. So this beneficial bacteria in constipated people also it's decreased. That is, when it is decreased, then obviously short chain fatty acid production. Sorry, 1 minute.
Dr. Sona, you need a couple of minutes break.
Yeah, just give me a break.
So despite not keeping well, Dr. Sona has been trying so hard for not only for making this presentation, but delivering it out in this webinar. By the time she joins back, Dr. Anders, uh, what does the future of probiotic looks like? What as India as a country, what are we expecting the next maybe a couple of decades for for probiotics in terms of new researches to happen?
Yeah, I think that there's a lot of interesting work going on around probiotics, science of probiotics, and new strains being developed and so forth. Looking at other health areas, looking at metabolic health, looking at cognition, looking at a whole range of different things. I think though that we still need this still needs a lot of work, I think, before we end up having something being commercialized. So I think that some of the science ongoing now will not deliver yet for perhaps another 10 years, 5 or 10 years at least. So I think that digestive health is going to continue to be really important. And I think when it comes to things like constipation, other strains may be useful when it comes to diarrhea and other symptoms, digestive symptoms. I think it will continue to be very important. But I think for now for the time being, but going forward, I think we will see some other new probiotic strains for other health areas as well.
Absolutely, because a lot of human trials have been being conducted globally on the role of probiotics, and I think uh, the next area would be definitely from a lot of metabolic disorders, diabetes,
Yeah,
obesity. A lot of things would be requiring probiotics as a management protocol. Dr.
yeah,
Hardik, we have been talking about the role of probiotics, and this is not new for us, but some new technologies will always keep on coming. What barriers do you see which limit the probiotic usage in a clinical practice? Is it cost? Is it about the doubt about the quality or uncertainty or the gaps about evidence? What do you see as a clinician?
I think the first one that you see is told is about the cost, and second is the evidence. Because till now the evidence is not so strong. Being a gastroenterologist and prescribing the medication, we usually taught only in the case of acute infective diarrhea for pediatric cases, those who have established IBD, and now there are certain, they are expanding more and more indications. But so there are very few indications where it has been probiotic has been proven role. So we need more and more evidence to say which subset of group of patients will benefit from constipation, which subset of patient with metabolic disorder will benefit from probiotics, or is it a there is a trend of protein being as a supplement right now. So do we need to take for a preventive health? Probiotic is going to take an that we need, and more and more evidence. I think cost is always an there, but this we need first evidence and then cost.
The market is loaded with a number of probiotics for what not indications. A lot of companies are there. Currently in India, in the last 20 years, I have seen more than 1,000 companies now selling probiotics. So you as a expert in gastroenterology, you told one is evidence, and then what are the other parameters which help you judge whether which probiotic or which brand or which company has to be chosen for?
So that we go with the highest, which is admin evidence. So that is usually because they come a lot more with, see, we don't, because probiotics, for making the probiotic, we need a good quality of plants and good quality of care and good quality of cold chain to be maintained. So the chain is maintained. So otherwise there is not no effect. So you're not going to know by clinically. So we have to trust the reliable source of the probiotic where you can procure from it, or which company you are prescribing as a molecule. And obviously, effect some when you prescribe some antibiotic in diarrhea, patients say, no, this one is very good. So for that, from that evidence, you make more and more solid to prescribe this particular products one again. Even in scenario where we found to co-prescribe with rifaximin. So we need probiotics which are antibiotic resistant. So that thing, I think that's a good, also is an important part when you're considering for probiotics.
Dr. Anders, I'll come to you with the same question. Like we have received a feedback from a doctor practicing in India who sees tons of patients daily who are related to gut issues. Now, for a doctor, what matters more is the evidence, the clinical evidence part, and also from which manufacturer the probiotics are coming from. But you told a lot about the techniques like micro encapsulations, which influence the survival and stability and whatnot of the probiotics. So, how do you think the same can be communicated to the clinicians also so that it makes a right differentiation in the minds of doctors when they are prescribing it?
Yeah, I think it's that this part with the stability. So we talk about efficacy. That's really important, right? Very important. But it's also important that we have the right levels in the product, in the capsule, so in the stick. And if they are not produced under the correct conditions, you may not have the clinical dose, the dose that's required. So even if you have a strain or a combination of strains that would deliver health benefits, you may not see it because the levels are not at the required levels. And I think it's something that is perhaps not discussed as often as it should be, the quality of the products.
True, and coming to the evidences, because a lot of work has been done and in the pipeline for the next maybe few years from IFF House. Uh, Coming to the evidence, what does the evidence say about probiotics for mental health, like gut-brain axis, metabolic syndrome, and NAFLDs are? So, what about the mental health, neuromodulation, mood?
Yeah, so there's some really interesting studies published in recent years, actually. There was one study published in 5 years ago that supports that some of the strains. So there's one strain in particular that will reduce the levels of perceived stress So that's an effect on mental health. There are other studies that they conducted earlier than that will suggest that you reduce stress and anxiety in pregnancy. So this is a study that was published back in 2017 using a Lactobacillus rhamnosus strain. Very, very interesting. So there are certainly data coming out and data available in the literature that relates to mood and cognition and mental health. Yeah. But I still think there's a lot more that can be done in that area. The studies that we've seen so far is I think we need larger studies also, and I think the strains that have been used so far, we may have strains that have much greater effect. But those are strains that we haven't yet been able to commercialize or scale up on an industrial level. So I think that there's a lot of opportunities here going forward. I think to develop further and identify and develop strains even further for other applications, stronger effects.
Hardik, you talked about the lifestyle of Indians, the cooking habits, or the traditional way of cooking, where dietary fiber usually is very low, physical activity is also very low. Indians usually are not much on the scale of drinking water very frequently, so the fluid intake is also very low, and there are other reasons as well to it. There's a very interesting question from Dr. Sambit Kumar Behera. Uh, Talked about dysbiosis. So he's asking a very simple question: can a probiotic be clubbed with an antibiotic as soon as the antibiotic therapies is started?
So I think very few probiotics which can be co-prescribed with antibiotics. Otherwise, I think the sir Anderson sir can better answer that questions. But if I know in clinical practice, very few of the probiotics co-prescribe with rifaximin or rifaximin resistance. I usually don't prescribe with conventional antibiotics. And usually I prescribe once the antibiotic course is over, then I prescribe the probiotics. When there is a post antibiotic, you need some inflammation is ongoing on body, and you don't want to give antibiotics at that point of time. I think sir can say a better answer.
Okay, Anders, would you want to add to this in terms of co-prescription of a probiotic along with antibiotics?
Yeah, so I think that if we look at if you look at studies that have been looking at antibiotic-associated diarrhea, for instance, some of those studies have done probiotics, administration of probiotics together with antibiotics, but it has been a time difference, so they haven't been given at the same time. So you take probiotics and then you take antibiotics separately. So you may separate the two supplements, so the two products by say 2 hours. And you see a significant effect or reduction in the prevalence of antibiotic-associated diarrhea as a result of that. So I think they do work if you prescribe in such a way. That's what at least some of the studies suggest.
I think Dr. Suvarna is back. So, Dr. Suvarna, please, can we continue with your presentation?
Sorry for the inconvenience, everyone.
No, I hope you're okay now.
Yeah. Means while talking, it is increasing, but it's fine. But please bear with me. So yeah, I stopped here regarding gut dysbiosis. Everyone is even the previous question is also like that. So what is really happening with the dysbiosis? What exactly happening means I already mentioned. So because of the less number of bacteria, the fermentation capacity will be decreased. Ultimately leads to lower production of short chain fatty acids. then impaired stimulation of gut motility that leads to constipation. So in a constipated people, because of the lower bacteria, obviously the short chain fatty number will be decreased and reduced colonic motility. And here one more interesting factor, in earlier Hardik presentation also he mentioned that methanogens. What are these methanogens? Why suddenly the number will be increased in the dysbiosis? What is the link between methanogens as well as this probiotic? Okay, so when the fermentation capacity is decreased, obviously the hydrogen levels are increased in the gut. So hydrogen is a source substrate for these methanogens. So these are different other kind archaebacteria. They are the substrate is hydrogen, then they utilize H2 and they produce methane. Okay, that's the reason they are calling as methanogens. Because of the methanogens, they have the tendency is they can reduce the colonic motility, ultimately leads to the constipation. That means whenever the probiotic, the beneficial bacteria is decreasing, methanogen bacteria will be increased because the environment is very competitive. So always they fight for the place. So whenever one number of bacteria is decreasing, other bacteria try to grow on themselves. So it's like a competition. So the number of methanogens increased, then it leads to constipation. So whenever doctor prescribe treatment, they need to first address the constipation is because of what, whether is it the number of methanogens increase. That is in the during therapeutic effect I'll speak with a different, that here I'm explaining the reasons why, what is the how it leads, dysbiosis leads to what kind of a conditions. Okay, what is the impact? Because of the reduced colonic motility, bowel movements will be reduced, and the reduced stool bulk formation. Because ultimately, why it is happening means maybe because of the less fiber intake. If fiber intake is not there, stool bulk won't be there, and definitely the number, whatever this much of stool needs to be passed, that number won't meet. And the increased intestinal transit time, it leads to constipation. This is gut biosis. And in next slide, I'll speak about what is why SCFAs are so important. If you see this a big slide, see here, if you see dietary fibers, even Hardik mentioned so many times, fiber intake. Why? How important fibers? Because our body, we cannot metabolize fibers directly. We cannot digest ourselves. So these fibers, undigested fibers, directly they go into the large intestine where probiotic bacteria, especially bifidobacteria, they can convert into short chain fatty acids, butyrate, acetate, lactate. Then they can enter into the epithelial layer from this. And earlier in the second slide, I mentioned that how they stimulate enteric nervous system, immune system, and followed by circulation, then other system. So this is the role of SCFAs. This is one of. So when dysbiosis happens, short chain fatty acid number will be decreased. Obviously, colonic motility will be decreased. These are the short chain fatty acids. And what is the mechanism of short chain fatty acids? They stimulate colonic smooth muscle contraction. So if muscle contraction is there, that means then only the movement, the peristalsis will be better. And they stimulate enteric nervous system by producing serotonin release. So here itself we get the evidence that they are linked with the brain neurotransmitters. If short chain fatty acid number is better, then they can increase the water and electrolyte secretion into the lumen, and ultimately stool can be passed easily. In the dysbiosis or in the lower SCFA producing bacteria, as a result, as we mentioned earlier, these are the symptoms. The reduced motility signals will be decreased, and the luminal hydration will be decreased because of the lower water. Electrolyte secretion will be decreased, and finally the sluggish bowel movements and evacuation. This is simply SCFA role in constipation because of the unable to take the lower fiber intake and excessive use of the antibiotics, and because of our dietary style, and maybe because of our metabolic disorders, or because of the aging, whatever the reason, ultimately the cause of this functional constipation is SCFA, short chain fatty acids, and followed by methanogens also. This is the role of methanogens in dysbiosis. As I mentioned earlier, beneficial bacteria number will be decreased, hydrogen availability will be more, then methanobacteria will be increased, The methane production will be increased. Finally, intestinal motility will be decreased. Ultimately leads to constipation. This is on motility. I think I can move to the therapeutic segment. Motility also already it is linked with enteric nervous system and gut-brain axis. How they important, how serotonin levels are important to activate this pathway. So I'm moving into therapeutic approach because this is most important, which is not covered earlier. This is right now. I'm not. It is a very personalized or precision approach for this one because if you are targeting only disease, only we can end up with the solution for the particular time. But we need to long term solution. We need to know. We need to understand what is the reason, whether it is because of our mm, lifestyle or because of what is happening exactly. We need to understand. So that's why I curated some of the pathways here. The microbiome based therapy. So that means restore microbial diversity. Whatever ways of maybe if you use excessive antibiotics, your entire diversity will be gone. So you need to restore. You need to restore and you need to increase the beneficial bacteria in the gut. Then obviously once we take this bacteria, then we can enhance the short chain fatty acid production and can be methanogenic bacteria can be reduced. And what are the approaches? Here, fecal microbiota modulation is one topic. That means maybe many people maybe they heard that is fecal microbiota transplantation. It is for severe cases. Right now, it is in nascent stage, in research stage, at least in India. In European countries, it is almost developed, and but so many plus or minus also there, but it is still under research stage. The second one is personalized diet based on microbiome. So nowadays, many labs are there. So to perform microbiome analysis, so around the costing around 8,000 to 10,000. If any patients come to the clinicians, if they are unable to identify the source, why they are not getting, better please recommend them to go with the microbiome analysis. Then at least will understand. They can understand whether it's a decreasing of bifidobacteria or lactobacillus, any particular species is lacking, or what is the level of short chain fatty acids. Everything in microbiome profiling they can get it. So based on that they can recommend which kind of probiotics can be used for them. This is precision based and personalized treatment they can be offered. So having these approaches we can focus on the modulation of this gut microbiota rather than simply relieving on the symptoms, because once we work on the symptoms only is a temporary relief only. So we need to address the issue. Then it's a very big good solution to go with the microbiome profiling. Then because they have comparative chart and nowadays it is evaluating much, so they can recommend what kind of a probiotic you need to use. And coming to earlier, I mentioned supplementation of the probiotics when dysbiosis happens. So what factors needs to be considered when we choose the probiotics and prebiotics? Always, Anders' first slide is strain specific probiotics. Already he mentioned. But in India, the problem is many products they don't have strain number on their labels. Suppose they mention Lactobacillus plantarum. Even doctors also, I don't know whether they consider this fact or not. Suppose they mention Lactobacillus plantarum. So for which plantarum they go for clinical evidence? If strain number is not mentioned, if strain number is there, they can search what are the clinical evidences around that strain, particular strain. They can search and they can recommend. So always recommend strain specific probiotics, because it is not like a paracetamol or any drug. So wherever the paracetamol is manufactured, the property of paracetamol won't be changed. But probiotic is not like that. Even though it's Lactobacillus plantarum, the kind of source where it is isolated, how it is manufactured, so the what kind of a conditions it's went through, based on that the properties will be changed. Some genes will be suppressed and some genes will be expressed. So probiotics we cannot consider like a drug. So better always, even if any clinicians, please check this fact that the label claim should be always, it should be strain specific. It should associate with strain number. And next one is we need to understand what kind of a disease it is, whether it is a slow transit, when functional constipation, what kind of a disease it is, they need to understand. That is based on that they can provide the treatment. And third one is having right strain, right CFU. And CFU also, and I'm seeing so much of publications or promotions, we are having 50 billion, 100 billion, 150 billion. So dose is not a matter. So with the dose, what is the clinical efficacy? That's matter. I mean, sometimes 1 billion also can give better effect. Sometimes 100 billion also may not. So it's depending on the clinical evidence, not on the right dose. So clinical dose is important, not higher dose or lower dose. Okay. So once we follow this right strain, right CFU dose, then definitely we'll achieve the right therapeutic effect. That is regarding precision. So coming to this, I'll come back again to this slide. I'll go to the next slide regarding precision probiotics. I want to slow some slides. This is one example from our portfolio. This is Bifidobacterium lactis HN019. So it is we have good clinicals on this strain. So this strain is used for reduction of colonic transmit time in healthy adults. This is functional gastrointestinal symptoms. They done randomized triple blind placebo control, and the key findings are the transit time, colonic transit time is significantly decreased here. If you see, they have done three groups: placebo, high dose, and low dose. That is the concept. Billions. They were checking. They checked that whether which billion, whether it's 2 billion is working fine or 20 billion is working fine. They selected three groups. Out of that, if you see the low dose, 18 hours compared to baseline, the transit time is decreased, and whereas 28 hours, it's improved in high dose. This is like that. You need to see this one. As I mentioned earlier, strain specific. Bifidobacterium lactis, many are there, whether it's HN019. So this particular entire studies belongs to this one. Even we have Bifidobacterium lactis BL04. So we cannot offer BL04 but this particular indication. So you need to see the strain number when you consider the probiotics. That's what I want to say. Along with the right kind of a probiotic, you can supplement short chain fatty acids, because to get the immediate relief, supplement along with the probiotics some of the short chain fatty acids also. And the third one is biomarker driven treatment. So we need to understand why the disease is happening. Earlier I mentioned methanogens. So whether is it because of the methanogens, we need to understand. We need to test by doing the breath testing. If it is methanogens, first we need to address it. Without addressing the issue, even though you supplement probiotics, if you are not addressing this methanogen level, so keep on this dysbiosis will happen. So first you need to arrest this methanogens number by giving the suitable antibiotics. Then you can suggest the probiotics. That is the way you need first. This will go up. First, they need to go for the precision diagnostics. They need to understand what is happening, why the disease is happening. So breath testing, then microbiome profiling and transit time assessment, what is happening, followed by prescription of the antibiotics to the methanogens, then followed by selection of the right probiotic for the patients. So by this using all these methods, what is happening means we no need to do trial and error. So it's a precision. So directly we go with the evidence based. So we understand this is the number. Then we can understand what is happening with the microbiome, where dysbiosis happen, what kind of a species we need to add. Then go search for the clinically evidenced strains. Are there any product is there? Then prescribe that product. Then obviously the time will be decreased, patient turnaround time will be decreased, and success rate will be increased. That's it. This is the keynote. As Ardik mentioned, of course, healthy lifestyle, healthy food, regular exercise, these are the best remedy. If sometimes if it is not in our hand, it is crossing our hands, then recommending personalized therapy based on microbiota pathology is the future. That's nowadays it's increasing. So anyone can do microbiota analysis. They can compare themselves, what is their flora, how it is behaving. So once if they change their diet, whether it is going into the right direction or not, it is like they can see visibly. It is happening now. So it is moving ahead from the symptom relief to precision therapy by using microbiome science, biomarker, and targeted interventions. And ultimately, you need to remember that while taking strain-specific probiotic, you need to check the clinical evidences, whether stability is there or functional claims are there or not. Based on that, you can choose the right probiotic. Thank you so much for listening.
Well, thank you, Dr. Sona. I think that was a wonderful narrative of the entire science of probiotics behind chasing constipation and managing constipation. Uh, have some water, please, because you're not keeping well. So we wish you good luck and good health as well. You talked about very interesting things. You talked about how this complex ecosystem of probiotics outnumber the number of human cells in a body, and we are moving from a nutritional approach to a personalized nutrition approach, and now to a precision-based nutrition. For a clinician, I think your presentation has a lot of insights to carry. While I was asking this doctor to Dr. Hardik also as to what helps him choose the right kind of probiotics when companies are coming with bubbling numbers. One thing he told right away was clinical evidence. Now you have topped it up with not only just clinical evidence, but the right strain
Yes.
is required to judge for that clinical evidence. So strain is very important. Label claims are again very important. And we are not just talking about the number of CFUs or dosages. It's all about the clinically validated dosages, which are very
Yeah.
important. So another third point which I noted, also while recommending the right probiotic to the right set of patient, it's also very important to check the methane level. So that is something which I have learned new today, the level of methanogens. I think I have a couple of questions for you, Dr. Suvarna. I mean, which chronic constipation patients are most likely to benefit from a probiotic-based approach? And how should doctors monitor this response? Yeah, Dr. Suvarna, so that was for you. I was just
Okay.
talking
Okay.
that, yeah, so chronic constipation is something which is rampant in India. So what kind of chronic constipation patients are most likely to benefit from probiotics, and how should doctors monitor the response week wise or maybe.
It's a, as I mentioned in the therapeutic approach, it's a functional constipation. They don't know the reason, but finally they are suffering with the problem. They don't know the reason. So sometimes it's a complex ecosystem. Until now, there is no theory. So that means this much of lactobacillus acidophilus should be there. This much of bifidobacteria lacti should be there. There is no norms. So this is based on the number of the patients and the area where we are taking, and even the microbiota will be changed from South India to North India, North India to Western India also. So that is based on the data, entire data. We need to understand this is the pathophysiology, this is the right kind of a dose. Nowadays, they are able to, I think, microbiome analysis labs, they are able to understand this is the disease condition, this is the recommendation they are giving. Say your short chain fatty acid number is decreasing, it is increasing. Based on that, I think we can take it up. But one more challenge here I can mention is it's a personalized nutrition. So that means, as Hardik mentioned earlier, cost definitely will go up because it is not for mass production. It is for precision based, means than particular patient. So it takes so much of effort from the doctors as well as the manufacturers. So we need to create the cohorts. Like suppose if you take patients from 100 patients from South India about the chronic constipation, we need to derive what kind of a changes are there in a microbiota, major changes in their microbiota. Based on that, for that South India, this is the precision based or microbiome based, personalized based probiotic formulation. Then cost will work. But each individual, it is difficult to manufacture product, right? So it is a cumulative effect from the effort from the people, doctors as well as the public also, as well as manufacturers.
I think very good narration, madam. And actually, patients comes up with the thick report of a microbiome panel.
Yeah.
So, a clinician, it is very difficult to interpret from that report. And for in a 15 minutes, I get report, I got through what to give, not to give. Be in just confusion. And as already madam said, North India and South India will be a different. So you need have n number of pharma to prescribe state wise. You
Yes.
need a microbiome, and you have to target
Yes.
according to that the microbial product.
Yes,
Right?
that means we need to create a cohorts, like based on that is maybe coordination with the microbiota labs, getting their data and analysis of the data. I think one lab from the Pune, they are doing that research. I think so. So that will give better relief for the patients if that kind of a data is out.
So one instrument is already there, that is methane bread test. So that is
Yeah,
already
yeah,
available now.
yeah,
And said the data from I think in the majority of work with Dr. Uday Ghoshal is from SIR's group, and they have said that methane producers are they can able to identify the bed rest, give treatment, and then you recheck again. So that subset of patients of constipation I think it's going to be useful for in a clinical practice.
Mm.
Dr. Suvarna, I mean, a lot of doctors are there listening to us currently. How
Okay.
can clinicians basically differentiate between a general probiotic and a probiotic which is meant for constipation? Is it only about the finding
Clinical
the right
evidences.
evidence,
Yes,
clinical
right
evidence,
evidence. Yes, yes.
or are there any some kinds of tools and I don't know, something available online where clinicians can go and find more about the role of probiotics which are more suited for constipation?
No, usually for constipation, bifidobacteria is a good number because they have the better capability to ferment these short chain fatty acids. But as in my presentation, if you see, short chain fatty acids plays major role in the constipation. So bifidobacteria number is you can take it up that as a good strains, probiotic strains, but it should have clinical evidences on the backup also.
Just asking some conclusion from all those clinical studies which have been conducted on probiotic
Mm.
specific constipation specific probiotics. What is a realistic time frame for improvement in stool frequency which a doctor should notice? Also in terms of the symptoms like consistency
One
of
month,
stools and bloating. 1 month.
1 month, yes.
And how long the therapy can be continued for someone who is
Means
a chronic?
along with the, they change their diet everything, then they need to monitor 3 months. 1 month the treatment period, then they need to wait for 3 months. If they are not following any, of course, definitely if it is health diet related, it can be corrected if they do. But if it is some metabolic or aging people, then they may need to continue. Based that is a patient to patient, it will vary. The effect will be varying also.
I think most of such kinds of patients will already be on some kind of laxative. Either they would have been recommended by a doctor, or they would
Yes.
have taken something out of
Along with the
Google
laxative,
research.
if they have probiotic also, it will have additional benefit because laxative, the lactulose, whatever these bacteria can, these prebiotics, along with the lactulose, if they provide some prebiotic like FOS or inulin, they, along with the probiotic, they can metabolize and they can decrease the colon pH, and osmotic pressure will be increased and stool will be passed easily. That is the mechanism is there. Means alone laxative, so many side effects are there, Dr. Hardik mentioned. So apart from that, if the patient needs relief means, then including attaching probiotics, it's a good idea. But they need to prescribe separately because these probiotics, they cannot be into the liquid; they'll die. Lactulose is a liquid; they cannot die, they cannot survive. So they need to prescribe separately, probiotic separate and laxative separate.
So can these probiotics help reducing the long-term dependence on laxative for these patients?
Yeah, it will be. Yeah, it can. Once the it's a multiple approach. So initially, for the immediate relief, they can add along with the laxatives. Eventually, they can cut down the laxative doses can be reduced. Then the dysbiosis will convert into eubiosis. Then constipation can be relieved.
Although most of the strains which are in question are supported by GRAS status by US FDA, but are they safe generally? How long can they be prescribed, or can they be taken? Can they be taken
Probi-
lifelong?
Lifelong, yes. Probiotics, they are already they are all our bacteria only, but because of the dysbiosis, we are taking from outside. So they are lactobacillus and bifidobacteria. They are having GRAS status. They can continue as a food.
And they will not be habit forming like the laxatives.
No, no, they are not having because they cannot colonize because they are also like aging. Aging is there. So the beauty of the probiotics from the point of manufacturer is they cannot colonize in the gut longer time. So they need to take it. So old
My,
generation is going off and new generation is coming like that. So they need to continue.
my question to Dr. Hardik as well as Dr. Suvarna would be, if what would be the right timing of recommending or taking these probiotics for constipation? It would be morning or night or any time of the day
After taking food.
after taking the food.
Usually, psychologically, patients takes in the evening, majority of the
Okay.
time before. So now newer medicines have come up that should be given pre-meals in the morning. Secretagogues, colonic prokinetics or secretagogues. But I think majority of the times patient usually take at the bedtime. They psychologically feel in the morning they will pass the stool, and that is I think very appropriate timings.
Dr. Sona, any key differences between dietary fibers which are prescribed for constipation and dietary fibers which should be taken along with probiotics?
Yeah, because along with the probiotics, we have the defined quantity. So from the diet, we don't know how much fiber intake we are taking. We feel maybe we are taking much. Whether it is a sufficient quantity or not, we don't know. Along with the probiotics, if you take, because we study what kind of a prebiotic the probiotic can metabolize, whether it is able to metabolize phos or inulin or polydextrose, we have the data. So with the precisely we can provide the amount of prebiotics. So it is more systematic way rather than having, of course, from the diet anyhow whatever the fiber they can get it, but along with that if they supplement along with the probiotics, it will be a good one because directly it can convert into short chain fatty acids, we know.
We have one question from Dr. Dulakshana Manohar from Coimbatore. She's asking a very good question about when any patient is on a long-term antibiotic usage. And Dr. Hardik, I think you can help Dr. Sumana in framing the right answer for this as well. Patients are on antibiotics for a long time. Is it possible to get the benefits of short chain fatty acids externally?
I'll take it up, Hardik, and he
Yes.
helped me. So
Yeah,
long
I
time,
don't, yeah,
long time antibiotic. It's like, see, for me, I'm taking antibiotic from 2 days. I felt like it's a horrible. Immediately started diarrhea. Just 2 days of antibiotic therapy. It didn't help me. Doctor really he didn't understand whether I have viral infection or bacterial infection. He recommended antibiotic. My throat infection is not at all gone, but finally I ended up with diarrhea just for 2 days only. So doctor, you are saying long-term antibiotic usage. So instead of correcting with short chain fatty acids, it needs to be corrected with the supplementation of the probiotics. That it can take care of the short chain fatty acids. But for the immediate relief, as you mentioned, supplement from along with the probiotics, SCFPs. But again, you need to consider about the cost also. That is one thing because short chain fatty acids they need to liquid, concentrate, drying, and again put it into the finished format product. Then definitely the cost will add it up. So of course it's a addition, but probiotic is a must. It's a long-term antibiotic usage means how much probiotic you need to use. It's very. I'm unable to imagine. It's very difficult because I started using Econom already from 2 days. It's very difficult. And one more challenge I saw is even I know that I have to continue antibiotic for 5 days. I know that doctor recommended 5 days when I start, but I stopped in between 2 days, even though I know what are the maybe it may turn into antibiotic resistance. Even though I know I couldn't continue. It's like 90% of the people they do. Doctor recommend 5 days of antibiotic, but most of us we cannot continue because of the side effects of the antibiotics. Some of the pathogens may not be killed, so it leads to very severe antibiotic resistance. It's a very prevalent in I don't know other countries because they follow prescription. Here without prescription also we can get the antibiotics. That is the most alarming thing. I hope
Dr.
I
Anders
answered. I
is
think I around I yeah.
Dr. Anders is listening to us very patiently. I have one question for him. Dr. Anders, do you think this some disturbance? Do you think this microbiome targeted therapies are going to be mainstream in the constipation management? And how far we are from reality today?
Yeah, possibly. I think we need to continue to develop the science. We need to continue to develop more stable strains. I think some of the strains that we'll see in the future will probably come from other groups than Lactobacillus and Bifidobacteria, and there might be some challenges to make sure that they are stable. For instance, they may have some great benefits, but they may not be stable enough. So I think for some of these strains, for some of these future developments, we have a lot of work to do. I think before they can become and can compete with traditional methods.
Dr. Hardik, coming back to you once again, how pathophysiologically, how do you differentiate between a functional constipation or constipation predominant IBS or defecatory disorders?
So basically, I told you again, the clinical practice, the functional constipation with versus IBS is the pain. Bloating can be a common symptom in both, but pain is the symptom which differentiate IBS-C versus functional constipation. That is one thing. Second, majority of the Indian patients when they come, they have already taken laxative, churan, Ayurvedic preparations, and stimulant laxatives. So we have left no medicines because they are all stimulant laxatives when they come. So when they come, we first see whether we can add something to them. For that, we need a colorectal examination to say about dyssynergia, and we do a anorectal manometry along with colon transit study to say whether patient is suffering from dyssynergia or not. And that subset of patient we can effectively treat. I can say in clinical practice 10-20% of the patient can be effectively treat when they comes to us. So uh, anything else? Your
You
volume
gave
is
a
not.
very brilliant perspective initially regarding the Indian context. So I think probiotic usage in constipation in India is still a novel approach. But would you think the HCPs, healthcare professionals in India, would relate to this novel concept once companies like us will start promoting probiotics, the right strains with the clinical evidence for constipation management?
I'm 100% sure because when patient comes, do something for me for constipation. That is the only thing. So you will add one armamentarium the treatment because I advise once we fed up, I advise you take 2 days stimulant laxatives, 5 days you take osmotic laxative. That is what I do right now. But if you have somebody's choice, I do 1 month you take this, 1 month you take this, 1 month you take this. So you get a personalized medicine more where which medicine suits best to you. So I think if you bring up with the medicine, there are only few probiotics currently available for constipation predominant treatment. But if you come up with that, I'm extremely happy.
Thank you so much, Dr. Hardik. And I think that was a wonderful discussion regarding the emerging role of probiotics, I must say, in the constipation management. May I request Dr. Anders and Dr. Suvarna to please put on your videos because I would love to take a screenshot so that I can remember this moment for a long time. Aditya, you can also please put on your video because the entire platform set by Dr. Anders in the beginning and then taken over by Dr. Hardik and Dr. Suvarna has been amazing. And I think whatever doctors have been listening to this webinar, and we'll be rolling out the recorded version to it on SNI platform as well. To those people who are not able to attend this webinar live, it was a wonderful discussion. Thank you so much, Dr. Anders, for the time of you have given. We have been chasing you for this, and thank you so much for remaining with us for the entire duration of this webinar. Dr. Hardik, Dr. Suvarna, thank you so much for sharing your experiences, insights, and also wisdom on a very complicated topic. I should say this is not a very easy topic, although probiotics are something which are the most talked about in India and also the most ignored. Although coming from a country which has been dealing with the fermentations from ancient history. So thank you so much for this, and also thanks to all our viewers who have been watching from different parts of the country. I mean, without your support, your passion, this would not never have been possible, and we'll definitely come back to you with another episode of NutriVigilance with some other topic, some other experts, and some other word health kind of a day very soon. Thank you so much. Thank you so much, audiences, and thank you so much, all our faculty members. Have
Thank
a
you.
nice time.
Thank
Thank you. Thank you, everyone.
Thank you.
Thank you, Jonathan. Thank you.